Hello everyone, and welcome to the Work and Mental Health, Developing an Integrated Approach webinar with Dr. Anthony Lamontagne. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships. As mentioned, my name is Tanya, and I'm moderating the session today and handling the Q&A. And our speaker today is Dr. Anthony Lamontagne. He leads the Work Health and Wellbeing Unit and directs the Centre of Population Health Research at Deakin University in Melbourne, Australia. His broad research interest is in developing the scientific and public understanding of work as a social determinant of health and translating this research into policy and practice to improve workplace and worker health. Currently, the unit's primary focus is on work and mental health, combining a range of etiologic and intervention research projects. I will hand it over to you now, Tony.
Thanks very much, Tanya. Hi, everyone. Thanks for beaming in. You might recognize a Quebecois name, those of you from out east. I'm a transplant to Australia about 15 years ago. Anyway, I'm happy to be here today and speaking to you all about work and mental health. I presume everyone can see the screen. The next screen there is just to let you know this was what I'm giving you is a updated version of a keynote that was given in Amsterdam back in June. So this is our group. This slide is to show you some of the contributors on the right there, but basically our purpose is to try to look at ways to make work as healthy and sustainable as possible. There's lots of other collaborators who need to be named as contributors to this work you'll hear about today, including some Canadian colleagues such as Peter there at the University of Toronto and other colleagues at UBC. So what I'm going to do is sketch the argument that I want to make to you today and then pick it apart or unpack it, if you will, throughout the course of the rest of the talk. So there's two premises or key points I want to make in the first place. Mental health problems are prevalent in working populations, and some of those are attributable to working conditions. That, I think, leads us to this take on an integrated approach, that therefore in order to have the greatest population mental health benefits, what we need to do is protect mental health or reduce the negative by in particular reducing the work-related risk factors. And secondly, where possible, promote mental health or by developing the positive aspects of work, as well as promoting non-work related protective factors, things like physical activity, for instance. And then third, we need to address mental health problems as they arise in the workplace regardless of their cause. And that regardless of cause phrase is quite important because, as you're all aware, when a mental health problem may be work-related, issues of compensation and liability and so on raise their head and complicate matters sometimes substantially. So this is saying the same thing but in a pictorial version, that basically these three threads are preventing harm, promoting the positive, and managing illness. But what's interesting about these is that historically they've each developed from their own in parallel, I could say, and you can see some of the disciplinary basis of each of those threads. And obviously there have been crossovers in the past, but I think in order to do the best we can in workplace mental health, we really need to integrate these three threads. So onto that first premise that mental health problems are common among working people. Most of you online here, I think many of you are practitioners more than researchers, but you'd still be aware that mental health problems are very prevalent, including in working people, obviously higher prevalence in those who are unemployed and not in the workforce. But in a given year, the Organization for Economic Cooperation and what's the D stand for? I forget, but the OECD has made estimates, collecting estimates from around across the 35 member countries, that on average about 20% of the working age population is affected by a mental health problem. 15% of those are mild to moderate, and about 5% severe, such as clinical depression, schizophrenia. That's quite a lot. The impacts are many. The impacts on individuals are around keeping your job, potential for discrimination for those who disclose or are revealed as having a mental health problem, not of their own doing. For organizations and employers, the thoughts tend to go towards productivity and organizational performance. From a societal perspective, is, as many of you will be aware, the fastest rising category of permanent disability is psychological or mental illness related, which is having huge impacts on our disability and support pension systems across the OECD. From a law and policy perspective, Martin Shane, one of your fellow Canadians, has written very eloquently on this around the issues that arise here. It's a very complex nexus. There's OH&S law saying that we should provide work that is psychologically safe, but that also, for the conscientious manager, he or she needs to navigate OH&S, anti-discrimination, equal opportunity, employment law. There's a number of things that come into play here. So what's the role of working conditions? Then moving on to that, that second premise. As you all know, work is a positive and a negative for health. Can work in both ways. The positives include income, work as a source of identity, as a source of self-esteem and self-efficacy, as a way of making social connections beyond your primary networks of family and neighborhood. All of these things are quite powerful and quite positive, and account, and to a large degree, for the distinction between being, generally speaking, work is better for your health than unemployment, although we have been able to show that the worst quality work is worse for your mental health than unemployment, which is an important point to make, and that's attributable to that long list of things you see at the bottom of the slide. In terms of working conditions that influence mental health, most of our understanding, and this is not a complete list, is around psychosocial work stressors, such as the level of control you have over your job, what the required demands are of the job, work pressure or workload. Job strain is the combination of a low control job in the face of high demands. That's particularly harmful. Social support at work can buffer the effects of various stressors, support from your colleagues or from your supervisors. Job insecurity needs, I think, no explanation, and I won't go through the entire list, but as I say, there are more even than can be listed here. The psychosocial work environment is really quite a broad umbrella, and rarely do we look at all of these stressors together when we think about mental health. But when you consider all those things together, you can see that there are quite substantial threats to mental health in workplaces that have these exposures going on. So what do we know about these exposures or for stressors in relation to mental health outcomes? There's a long list of outcomes that have been associated with these stressors. Poor mental health in terms of things like scaled measures of mental health and well-being, the short form 36, for example, or the Kessler-6 as a measure of psychological distress. Depression, including diagnosed depression or depressive symptoms, anxiety, diagnosed again, burnout, and most recently the evidence around suicide as associated with job stressors is growing substantially. We just published a study of 9,000 completed suicides in Australia over a 10-year period and showed a link with low job control and high job demands among men, who account for 3/4 of suicides. The longer, more established evidence is around, for instance, depression, or job strain. A recent systematic review and meta-analysis of job strain and depression by Theorel, one of the creators of the demand control model, showed about a 75% increased odds of depression when exposed to job strain, almost a doubling. And then at the last point on the slide emphasizes that unlike a lot of occupational health hazards, historically, these are not rare exposures. Like asbestos, this is a horrific toxin, increasing the risk of mesothelioma and lung cancer, but the proportion of the working population exposed is fairly low. Proportion exposed to job strain is on the order of 15 to 25%. Women much more so than men, and that's attributable to the persisting basically sexism in the workplace, where women are in lower control positions even in equal occupations still to this day. We have a long way to go there. What this means in short is that exposure to these stressors translates to substantial preventable illness burdens. So when you know how prevalent an exposure is and how much that exposure increases the risk of a given outcome, you can calculate the attributable risk of that exposure. So we were able to calculate in Australia that job strain accounts for about 13 to 17% of depression in working people. And some colleagues in France, using independent estimates of both exposure and the effect, how much increased risk there is, came up with comparable estimates a little bit higher than ours. As you can see there, 10 to 30%, 5 to 34%. The higher burden among women in Australia is attributable again to that higher exposure to job strain among females. Now, there's lots more to know in this space, but we're not going to go into that. These are just a sampling of the questions. There's loads of issues around cost. If we were to account for all stressors in the workplace and all associated mental health problems, we'd see a lot worse picture than what I just showed you for job strain and depression. And we also don't know, well, how much exposure over how long is an issue. That isn't well understood. And ways of measuring, there's lots of controversy around this scientifically. Gee, most of these stressor measures are self-reports, and so isn't it all about perception? Well, the answer is no, because we can also have some measures of objective stressors, but there's more to be done there. And what's the response? Should it be standards or regulations? Should it be guidance? Should it be voluntary? That's a debate that's being actively played out as we speak. So that finishes what I have to say about those two premises, and I hope it's convinced you that I'm sure you didn't need convincing that mental health problems are prevalent, but I hope now you have a better appreciation of what proportion of those, a substantial proportion, could be attributable to working conditions that, in theory, are under our control to improve. So that brings us back to the integrated approach, and now what we'll do is we'll step through each of these threads, and I'll give you a little bit of a précis on each of those, starting with preventing harm. So in terms of dealing with work-related stressors, what to do is reasonably well established. Systematic reviews in the area say that if you combine work-directed and worker-directed, that means deal with the working conditions and deal with the worker's resilience, for instance. Another way of saying that is stress management is about dealing with the impacts of stress. Prevention is about improving the quality of work, for instance, and people's resilience so as not to experience the effects. A systems approach is another way of saying the same thing, comprehensive the same. And what's common to all of these is that genuine participation in identifying the stressor issues in a given workplace and deciding upon the responses is quite important. And as you could imagine, job control being one of the central stressors in this story, a participatory approach would be the embodiment of job control in that respect. This is just to illustrate for you the multidisciplinarity of dealing with this problem. So if we go from working conditions across to enduring health outcomes such as depression, diagnosed depression, someone might be distressed at work and feel tension, for instance, as a short-term transient effect. A short-term response to that might be to go have a smoke or go for drinks after work, or just to end up with a headache or something. But enduring health outcomes can follow, and in responding to this, as we go from left to right, OH&S is really in the working condition space, organizational psychology, psychology and medicine. There are many more disciplines we could lay in here, but in short, the language from public health, which will be familiar to some and perhaps not others, is the further up, closer to the source of the hazard you go, is primary prevention. Dealing with the effects at the individual level is secondary intervention, and dealing with the resulting problems for the individual health effects is tertiary intervention. This is saying the same thing but slightly different, and it adds a nice element here, and that is on the right of the figure you can see in the stress response. Eustress versus distress. Eustress means good stress, or translated to plain English would be challenge. most people like some challenge in their work. It's a way of promoting self-efficacy, staying active, and this can lead to positive outcomes, which we'll come back to in subsequent slides. Now, the challenge here is that unlike when we have a dangerous machine that could cut off someone's fingers, in that instance, we can just fit a machine guard and the problem is solved and never needs to be worried about again. For each stressor problem in a workplace and for each individual to some extent, the solutions are unique. So how to do this is much more challenging than what to do. So for instance, improving job control for you versus me versus a convenience store clerk, a police officer, a primary school teacher, those are all different things. So the principles are common, but the solutions are unique. And we do have generic concepts and constructs to guide this process, but it's never simple and automatic. Tailoring is required, depends on the context and so on. This is where things, in my experience, tend to slow down for a well-intentioned organization that's trying to address this problem, because this takes a bit of work. Now, when we turn and look at prevalent practice, this is from Australian study of ours, or a series of studies of ours. There is still, just like a lot of issues around mental health, there's still a persisting view of job stress as an individual-based problem. You can't stand the heat, get out of the kitchen. In some instances, there may be elements of that, but certainly not on the population level, as we've been able to show by the epidemiology. There's stigma around job stress as well as around mental health problems, and it's important to distinguish between those two. They are slightly different and require slightly different responses. Also, what we found in our qualitative studies was even among women respondents, mental health problems being portrayed as a stereotypically feminine weakness, persisting sexist view, and furthermore, employee assistance programs, or EAPs, were the most common response we got from organizations when we said, well, what are you doing about job stress? Oh, we have an EAP, and it's fantastic to have an EAP. That's quite a valuable thing to offer employees, but it's not an adequate response in and of itself to job stress issues. And finally, insurance-driven responses can conflict with public health responses. By that I mean our insurer in the state of Victoria, Australia, does recognize work-related mental illness and does compensate it, but many of its early responses were really as much about limiting those types of claims as they were about dealing with stressors. So there can be a conflict there between insurance and public health mandates. So that's it for the first thread, and I would just summarize it as saying that the preventing harm is stressor-based or focused. It's upstream. It's focused on the organization of primary prevention. It's, of course, weaker on the other end, dealing with illness and so on. There's little in here about promoting the positive, and that's been an important gap that we need to fill, which we're coming to next. And there is a disconnect between evidence-based best practice and prevalent practice. So now let's turn to the second thread, and that is promoting the positive. So some definitions first. This is probably the newest kid on the block in terms of workplace mental health, but an important one that is developing rapidly. If we go back to some of the early definitions around positive mental health or well-being, you can trace this back to WHO in mid-last century, looking at complete health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And that has developed further, including to definitions around complete mental health as having high well-being and in the absence of mental illness. It is also possible, though not common, to have high well-being in the presence of mental illness. And this is Corey Key's definition that's at the bottom of his model. Another way of thinking about this is that the main components of well-being or positive mental health are having some meaning and purpose, and that's the eudaimonic, and then having positive feelings or emotions, and that's the hedonic aspects. And so this is Another way of defining this in terms of the workplace, or what it's about in the workplace, is the aim is to promote individual flourishing as well as organizational flourishing. And positive approaches tend to focus more on avoidance goals, so to move from avoidance goals, which is sort of an OH&S approach, deal with the negative, to approach goals and to pursue the positive, to encourage develop, for example. What are some examples of methods and outcomes, therefore, that might be focused on? Well, appreciative inquiry and future search. Appreciative inquiry means not just looking for problems in a needs assessment, but trying to figure out what you're doing well so that you can build on those strengths as well as address gaps. Future search is another example, or other language, strengths-based development. There are other approaches as well. The outcomes that might be pursued or could be well-being or trying to promote challenge. How do you stretch people in their work, give them the challenge that they want? Promote positive employee capacities such as engagement in work or resilience, and also positive organizational attributes such as a positive work climate or culture and workplace social capital. Here's some other examples: human resource development of positive individual capacities, focusing on people's cognitive appraisals of meaningfulness, manageability, or hope. At the organizational level, we're doing a trial in Victoria Police now that focuses on supportive manager behavior. There's another example there, positive manager behavior. Others have focused on promoting a culture of respect within workplaces or social capital within the workplace. When one looks across what happens in workplaces, sorry, this is a bit of a busy slide, but that circle on the right basically says that health and safety, employee assistance programs, comprehensive corporate wellness programs, workplace health promotion, and so on, tend to neglect the positive aspects of mental well-being. And this is a gap that is rapidly being filled by a whole range of different programs that are coming into workplaces these days. So what's the evidence that this does any good? There is a fair bit, but it tends not to be focused on the workplace application of positive approaches. There's a large meta-analysis that was done some years ago that showed you could sustainably enhance well-being and mitigate the effects of depression with positive interventions, and there were particularly greater benefits among those who were depressed experiencing these programs. There's also a study that we did recently looking at positive mental health and showing that it mitigated the effect of job stress on psychological distress. So in other words, to the extent that we promote positive mental health, that's a good in and of itself, but that's also a buffer against the effects of stressors and negative outcomes. A review, the closest thing for the workplace setting is a review done by Myers a few years ago, and that came down to 15 studies, but the evidence said that you could enhance employee well-being with these programs. There was mixed evidence that they led to enhanced performance, which is sort of the holy grail from the employer perspective, and there was some evidence of the alleviation of stress, depressive symptoms, burnout, and anxiety. So hopeful, but more could be known, obviously, in this space. Also like to acknowledge that in promoting the positive, you can also focus on non-work related protective factors or programs such as general mindfulness training or physical activity that aren't work directed. And those are an important aspect as well. It's in essence using the workplace as a setting for health promotion. So to summarize that quick tour of promoting the positive, we'd say that one limitation is that the emphasis has mainly been on the individual level to date, but there are efforts to move to focusing on teams, groups, organization levels. In addition to promoting well-being, positive approaches may mitigate or moderate the impacts of the negatives on ill mental health, which is sort of a double benefit, if you will. This is nevertheless the least developed of the three threads of the integrated approach as we're presenting it. We can also acknowledge that if you are able to promote positive aspects of work, it can also provide a foundation for the promotion of non-work related protective factors in the workplace as well. So that concludes our quick tour of promoting the positive, and now let's go on to the third thread of managing illness. Over the last decade, many of you will be aware there's been a huge influx of mental health programs in the workplace. And for many of these, some of them have been around promoting the positive, as we were just discussing, but probably more have been around mental health literacy and anti-stigma campaigns. And mental health literacy we can define as the knowledge and beliefs about mental disorders which aid their recognition, management, or prevention. This is Tony Jorm's definition from a couple decades ago. And what this is basically is education around the recognition of mental illness, knowledge that it's usually treatable, and not a personal flaw, and so on, so the anti-stigma elements as well. And then it usually includes skill building around both recognition and how to seek help yourself or offer help to someone you think may be affected. This obviously can enhance the effectiveness of treatment, rehabilitation, and return to work, which is a prominent feature of dealing with work-related illness regardless of cause. But to the extent that there's low stigma and high literacy around these issues, that would enhance return to work as well. So examples include mental health first aid. Beyond Blue is a national workplace program here in Australia that started a little over a decade ago, and Are You OK Day, which is a suicide prevention focus, but again really around literacy and help seeking and helping people to learn how to offer help to others. Now, one key feature of this is that it's been hugely embraced by employers, which for the likes of people like me who focus on job stress, I'm a little jealous. It's much harder to get employers to focus on things like job control and security. But to the benefit of all, this has been widely embraced by employers. Oops, I've got a double slide there, apologies. And to me, as an opportunistic public health person, this has provided a new entree for job stress intervention where I might not otherwise be working. And over the last 10 years, I can see how that has opened doors for me that would not have happened as an occupational health person. So I tend to see this as an opportunity for expanding a focus on workplace mental health and moving upstream a bit to argue to employers that in addition to hosting Are You OK Days and so on, they could think about the impact of working conditions on people and trying to optimize those to the extent feasible in their workplace. That's just a little bit of an aside, but I'm just trying to acknowledge a little bit of the intense trends that have been happening around workplace mental health in the last decade. Been really a very positive thing, but one that I'd love to steer a little bit further upstream. So what's the evidence of effectiveness of these programs? There's not a lot of very specific systematic reviews, at least the last time I looked. There was one done in 2009 by Ange Martin et al., and this was for a variety of workplace mental health interventions, not just those focusing on mental health literacy, but what she found is small positive overall effects on symptoms of depression and anxiety. And there are some specific trials that have been done, particularly by the inventors of mental health first aid, Tony Jorm and Betty Kitchener, showing increased or improvements in mental health literacy in workplace trials, and also some evidence of improvements in mental health amongst participants in workplace settings. So in summary then, on that quick tour of managing mental illness, it is illness-based, strong on the tertiary, weak on the upstream or primary, individual focus, little on promoting the positive, although one could argue that getting people to seek help and offering help to others is a positive in itself. The evidence base is developing, and this is strongly embraced by employers and provides entree for workplace mental health programs. So there it is again, just to acknowledge there. And what I'd like to say is one of our goals in thinking about the integrated approach overall is to move from a definition in the workplace of mental health literacy towards workplace mental health literacy as the knowledge, beliefs, and skills that aid in the prevention of mental illness and the promotion of well-being in the workplace, and the recognition, treatment, rehabilitation, and return to work of people affected by mental illness. So that's sort of a quick tour, and I also want to acknowledge that this is happening to various degrees internationally in policy and practice. There's an excellent program in Canada called Guarding Minds at Work that many of you will be aware of. The UK's got some things going on, as well as the European Agency for Safety and Health at Work, and Canada's standard for psychological health and safety in the workplace is an important effort in this space internationally. Now we're turning to some of our current research in this area to show you what we're trying to do with this concept of an integrated approach and how we're trying to make it happen, if you will. We've been working with Victoria Police here in the state of Victoria, so that's where Melbourne is, down the lower right corner of Australia. We've been at it for about 5 years, starting with really sort of relationship building studies of us trying to understand what's going on through qualitative studies and so on to figure out what are the drivers of mental health and ill health, what's Victoria Police ready to do, what are the perspectives on the problems and solutions from the ordinary ranks or troop level up through the top brass of the organization and so on. And after a couple of years of that, we were able to get a cluster randomized trial funded to test the implementation and effectiveness of an integrated workplace mental health strategy. And this is what it looks like in diagram form. So on the left are the activities that we're doing. In the blue there in the second vertical column, if you will, are the target groups, which if we succeed in reaching those target groups with those activities, we would have the short-term outcomes of improved mental health literacy, as well as improved working conditions. And to the extent that those things happen, in the longer term, on the far right, we should see reductions in perceived job stress, improvements in mental health, and possibly improvements in productivity and performance. So if we go back across to the left to the activities, you can see that we have baseline survey and feedback. That there's to each station, sorry, I should say the cluster is the police station. It's 24 stations involved in the study. We do a lot of focus on station command, trying to improve the culture and supportive leadership within the station, and that ties sergeants and senior sergeants are the people who run police stations in Victoria. So we do a 360-degree capability assessment and feedback process with the station commanders. Then they're offered 4 individual coaching sessions, and they identify 3 goals, one positive goal, one focusing on a strength of theirs, and one focusing on a gap. Thus far, we've really struggled to make that happen. In the first part of the study, we were only getting about 2 out of 4 sessions completed, and we've made a lot of extra effort together with Victoria Police to try to bump that up to 4 as we get towards the end of the trial. And nevertheless, that's been very challenging because of workload and people finding space to do this. We also focus in terms of the troops, that is the ordinary ranks, the people below the sergeants. There is a workplace mental health literacy training called Healthy Minds at Work that's delivered to all staff, as well as a manager session that's delivered to sergeants, and that focuses, in addition to looking at stressors and mental health and general mental health literacy, it also focuses on responsibilities of managers legally and ethically and so on. So as you can imagine, looking at this, there's many other things one could also do to try to improve workplace mental health, and we were just not able to do much more than this in terms of what was feasible and what the police force was ready to try on. So wish us luck on that one. The results on that should be in early next year. There's the design. I guess I've already explained that. 24 stations randomized to intervention or control. There is a lot of detail on this for those who are interested in a protocol paper, including a detailed description of the intervention, which is probably more of interest to practitioners than the technical aspects of the trial. Now, doing cluster trials or trials of intervention studies is really important and needs to keep happening. However, those are hugely expensive, take a long time to do, and also their generalizability can be questioned. That is, not all organizations would be willing to take part in such an intervention, and those that would and versus would not. There's always questions about whether you're just dealing with the best actors in the working population when you do these studies. So what are alternative approaches to doing intervention research? We're trying to figure out what we can do or what might have impacts on mental health. And this we've been spending a lot of time thinking about. This slide really just sort of summarizes what I said before. Obviously, the gold standard in intervention research is a randomized trial where we can say with the greatest confidence that differences that are observed are related to the intervention and not caused by something else. That's the whole idea of an experiment. And another way of saying this is that individuals or groups in the intervention versus control condition are exchangeable except for the exposure that gets manipulated. That is, the workplace mental health program or otherwise. This is that point about I just made about intervention studies being very challenging. We don't need to go further on that one. So what we've come around to is trying to use existing data to capture natural experiments and basically apply experimental thinking to non-experimental data. So the key features here would be you're looking at interventions that are not undertaken for research purposes. That is, they're naturally occurring. It might be a political policy decision. It might be things that just happen, such as downsizing and restructures. But the key thing is the researchers do not control the exposure. But we do make believe that it's as if people are assigned randomly or not to that exposure. And that isn't entirely justifiable, but that's what you do when you're trying to make the best meaning you can out of natural experiments. So there's all sorts of analytic methods. These probably aren't of interest to you, and this is a rapidly expanding area. Suffice it to say that in our group, we're borrowing methods from econometrics, this thing called fixed effects regression. And the key thing about this, not the technical stuff, is that if you have multiple measures on one individual over time, then you can use the person, him or herself, as their control, as their own control. So you can compare what happens within a person as opposed to comparing different persons or group. And what this does is it rules out the contributions of things that don't vary within an individual, their sex, their early childhood experiences, their race, ethnicity, disease history, and so on. So we use this to do an experiment around job control, if you will. So the trial evidence around job stressors and so on is still needs more. There's some there, but there's still more needed. So what we know mostly from the epidemiology is that when job control gets worse, mental health gets worse. But what we really want to know is if you improve job control, will mental health improve? That's the intervention side, flip side of the same question. And so that's what we were able to do in a study of 15 years, about 10 or 12 years of repeated measures data in a large Australian population-based study. So just to illustrate this idea of looking at within a person and the change, you can see the farmer there. The blue line is his mental health, and the red line is his job control as he reports it over the years. Each dot would be a year. And this portrays a relationship between job control and mental health, which is what our hypothesis was. And people have ups and downs in job control and ups and downs in mental health, and this we can see in the cohort data over time. The young professional woman on the bottom panel there, her story would be one, hypothetical story again, would be one of improving job control over time. For example, as she moves up the occupational status ladder and her mental health improves with it. So we were able to test this using that fixed effects regression, each person serving as his or her own control. And what we showed was that as job control improves, mental health improves in a stepwise fashion, as you can see illustrated there by the blue dots. The dots on either side are the confidence limit, showing that these are significant improvements over time. So this is just a way of trying to go into large population databases and contrive experiments, if you will, and then extract the data from them. The key point here too is that these are changes in job control that are happening in the population for real. And so the generalizability of these findings is clear. It's not as strong as an experiment in terms of causal inference, but this is real stuff that's happening as opposed to interventions that researchers are making happen in one or two workplaces, for instance. So we've done a lot of that. I won't bore you with those papers, which you can look at later. Here's another thing that we're doing with Victoria Police. There's a very great concern about suicide amongst police officers. I know also in Canada, emergency responders is a big initiative there as well. And we're doing a project currently around systems evaluation for the prevention of suicide in the Victoria Police. And what we're trying to ask is, outside of dealing with the public or the operational stressors of conducting police work, how do the systems of the organization affect member mental health for better or for worse? This was driven by an awareness amongst police psychology unit staff that some of their systems, for instance discipline, conflicted with well-being. For instance, when a police officer for justifiable reasons legally is accused of some misconduct and then is suspended and not allowed to speak to any colleagues and so on, that isolation is obviously a negative for mental health, and suspension is a high risk factor for suicide, whether the individual is proved to be guilty or not of the reason, the charge for which they were suspended. That's just an example of where the impetus for this study came. So we're taking a systems dynamics approach to this, and what you try to do here is essentially to identify levers for intervention by developing a picture or what we call a causal loop diagram of the various influences on mental health, and you build that picture step by step with police officers in this case through a multi-meeting, or 3 meetings in total we did, building the systems map. And these are pictures from the actual workshops that we did. And this, sorry it's a bit overwhelming, but I'll talk you through it, is the causal loop diagram that the police officers generated. So the different colors represent different domains, if you will, of influences on mental health. On the upper left, that gray, I hope you can see the color, the gray there is around seeking help, mental health literacy, and so on. On the top and the top right, the purple, is around external influences, family issues, life pressures, personal issues, alcohol, substance use. Workplace conflict, you can see, is a real focus and a real confluence point. The blue on the left is from around leadership and what it might have to do with mental health. And the yellow is around job pressures, and job stresses, and so on. We don't need to go through the whole detail, but what's key here is where you have high confluence points, such as workplace conflict right in the middle, and coping skills in the center right, stressful work environment in the center right as well. That suggests that if you can make a difference in those places, you can influence multiple things and therefore perhaps have greater impact. So the next step research-wise is where you can quantify these relationships. You can actually simulate experiments and see what the impact would be of tweaking different parts of this systems map. So that's enough to say about that, but it's a new approach and its application is likely to grow. And it is being applied in other areas such as traffic injury, as you can look up if you're interested in that paper at the bottom there by Thompson. So finally, to conclude, I'll just say a little bit about what we're trying to do around moving from looking at evidence-based practice and practice-based evidence. We're doing a series of things around developing Delphi guidelines for workplace mental health, both promoting the positive, for instance, and you can get these links from the slides later, and we've done previous ones around returning to work from a mental health problem and also on the prevention of mental health problems in the workplace. Most recently, Natalie Bavopoulos, as part of her PhD, has done an adaptation of mental health first aid guidelines to the workplace setting, dealing with issues such as, power dynamics, supervisor to coworker mental health first aid, and the issues that might arise there and how they might be addressed. So in short, these pictures here are what I've just been talking about, illustrating that we're trying to develop resources to support interested organizations to have a go at these different threads and develop their own integrated approaches. So a couple of cautionary notes about the integrated approach. We need always to be mindful of an overemphasis on the individual with mental health programs. As you've gotten from my talk, I'd like to focus as much on the work environment as the individual. A lot of employers get confused by the plethora of workplace mental health information, activities, programs, and they get confused about what's mandatory and what's voluntary. And that's something that we need to be mindful of. There's obviously always confidentiality and privacy issues, and in a lot of workplace mental health intervention, there's naturally a focus on softer targets that are not nearly as likely to have impact on mental health as the more challenging targets, such as things like job control and security. There is also a problem in that those most in need, for instance, lower status workers and precarious employment, they're the least likely to receive these programs, and yet ironically the most likely to need them. And this can lead to exacerbation of inequalities. While it might be raising up those who are at the higher occupational status end, it can be leaving behind others, which is known as the prevention paradox. So something we also need to be mindful of in our approaches. So summing up then, with an integrated approach to work and mental health, we could get greater reach for job stress and mental health literacy intervention. We could rebalance focus on the work as well as the worker, leading to transferable work, non-work skills around mental health literacy and other things, improve mental health well-being, and possibly preventive synergies by doing those things. So I think I'll close there and just acknowledge that today is also the World Day for Decent Work. Coincidentally, we didn't plan that. Those of you interested can have a look there. There's a Canadian flyer around what decent work is: meaningful and productive, paying a living wage, benefits, social protections, and so on. Not far off what we've just been talking about. So thanks very much. I'll end it there and happy to take some questions.
Wonderful. Thank you very much, Tony. That was a very good presentation. We have a question about the police study, and someone was wondering how was job control measured? So it was a real change, but how was it quantified?
Oh, okay. So that was the natural experiment one?
I think so.
The natural experiment study. I think so, yeah. So, because that was not in the police, that was in a large population survey. So job control was measured with, 4 items from the Karasik demand control model. And so that's how that was measured. It's usually measured with more items, but that's what was available in the longitudinal cohort. Sorry, I'm flicking. This is the study we're talking about here, right? Oh, can people still see the slides? I don't actually know if they can.
Yes, they can.
Oh, they can, yeah. So this one, job control is measured, yeah, with 4 items.
Okay.
There's more detail on the study, published study there, at the bottom of the slide.
Okay, great. Let's see. Everybody feel free to type in any questions you have. There's not any at the moment. We'll just give it a minute here for anybody to type in.
Mm-hmm.
Out of curiosity, what are the types of job control changes that you've seen that make a difference, just on a very practical level?
Oh boy. Well, so the challenge here in answering that question is that every job is unique. All right, and the way job control manifests for every worker is unique, and so the main components of job control are, one, your ability to make decisions about how to do the work. That's half of the job control measure. The other half is called skill discretion, or your ability to use a variety of skills in doing your job. That's to prevent monotony and, promote self-efficacy and so on. So some of the things that are done, for instance, for very monotonous work, some of the interventions that have been done historically is to rotate people through jobs, for instance, in a factory setting where you'd be doing the same thing all the time, so that you could have some more diversity and use a wider range of skills. So that would be focusing, for instance, on skill discretion. And on decision authority, from a qualitative study that we did, I can remember a quote from a woman who was a receptionist in an office setting, and she had a boss who required her or dictated to her that she had to do the photocopying at this time, and she had to do this way and so on, and it actually hampered her ability to get the job done because she wasn't allowed to order things. Very simple. She wasn't allowed to order things and do things as needed and juggle things because, of course, in the middle of all this, you'd have people coming and going from the organization, and it was her job to be greeting them and getting them to the right person inside the organization. So that was a simple example of an overbearing manager treating a lower status worker, but of course, that job is more complex than it might seem and requires communication and interpersonal skills as well. And there was very simple interventions that would have allowed that woman to do a much better job for herself and for the organization. So there's a couple of examples.
Great. Someone wondering, how difficult is it for you to get into workplaces or to get workplaces on boards? Do you get a lot of pushback from employers when trying to implement these things? Essentially, this person's looking for us, like, what's the selling point? How do they talk about the benefit to the bottom line, or whatever, for talking with their own supervisor?
Okay. Yeah, so what I can say about this is that over the 10 years or more that I've been working in this space, it's gotten progressively easier. But I have to say, as I highlighted in the talk, that I tend to focus on the mental health literacy aspect when I'm getting in the door. And I don't lead with job stress reduction because that turns off a lot of employers. They're afraid of it. And for instance, in one study where we were trialing a feasibility study around integrated approach in a blue-collar factory, it was a window manufacturing factory in Melbourne. In the negotiations to get this work site to participate, what it came down to was the health and safety manager saying, well, what we really want to know is if from this study we participate in this, you're going to increase our stress-related claims. And my answer to that was, well, I doubt it, but I can't guarantee that I won't. And you do have regulatory responsibility to protect psychological safety as well as physical. And if you participate in this program and do what you can to address work-related risks to psychological or mental health, then if and when you are a claim arises or you're inspected by the OH&S regulator, you'll be on the front foot instead of the back foot. And in the end, that group did participate in our study. And so, I mean, there's just a couple of examples. To flip that around, with the Victoria Police, they came to us because they had such a huge problem. They have the highest stress-related claims in the state and in the workers' comp system. And there's been a growing awareness on the part of Victoria Police of the need to try to deal with this. And so that was an example of an employer seeking us out, which is relatively rare in my experience, but it's becoming more common. I hope that helps.
Great, thank you. We don't have any further questions, and we are pretty close to time, so I think we'll go ahead and end. Thank you very much, Tony, for the presentation. It's very informative, and I know I've gotten several comments of people saying they're looking forward to reading some more of the studies and getting a little more into the data, so that's really great.
Excellent. Well, thanks everyone for attending, and best wishes.